I'm Jo Raven, and I'm chairing this session today, ably supported by Clara Burton on the online questions over there. So for all those who are online, please do submit some questions for each of the sessions that we have. So we all recognise that health systems need to be resilient, to adapt and flex when there are shocks and stresses, so that health services, whether they are HIV, malaria, maternal health, TB, NTDs, all these areas that we have been talking about over the last day and tomorrow as well. So those continue to be delivered equitably and with good quality. So resilient health systems, it sounds so simple when you say it like that. But we have some amazing speakers today who will unpack this and really showcase some of the research that LSTM is doing with partners in the area of resilient health systems. We have another session on health systems tomorrow. So we start with the LSTM strategy for resilient health systems and learn about our new Institute for Resilient Health Systems. We then will take some deep dives or focus in on specific areas. So health systems in fragile, shock-prone and conflict-affected settings. Community health systems and health workforce and their role in resilience. Research capacity strengthening and its relation to health systems resilience. And then finally, we have our keynote speaker who will challenge us to reflect on what health systems resilience means in practice. So, let's get started. Exciting lineup. So I would like to start and welcome to the stage Dr. Marisa Koch and Dr. Jacinta Nzinga, who are researchers in health systems here at LSTM. Welcome.
Good morning, everyone. My name is Marisa Koch, and I'm together with Jacinta Nzinga, as said by Jo, and we're going to discuss a little bit about LSTM's strategy in terms of resilient health systems and the setting up of the new Institute for Resilient Health Systems. So why is health system resilience important? Well, I think we all know, but just to remind ourselves, countries are facing multiple shocks, re-emerging infectious diseases, emerging infectious diseases, worsening climate change, resulting in climate-induced disasters like flooding and heat waves and protracted conflicts. And the frequency of these shocks is expected to increase over time. And the shocks are also linked to each other, as we have already discussed in the previous session. And these shocks, crises, emergencies, they occur in a context of chronic stressors. And these chronic stressors are often more prominent in low-income settings. Poverty, economic constraints leading to high food prices, leading to resource scarcity. Migration is another stressor. AMR, pollution, extreme heat, and so on. And this is bringing us to an era of polycrisis. Many settings are facing multiple and simultaneous crises that are often systemic and cascaded in nature. And this stresses coping mechanisms of systems at all levels, including the health system. And these shocks are leading to deaths directly, but more often, or actually often, people die as a direct consequence of crisis. People die as a direct consequence of crisis, but more often from unaddressed preventable conditions because of the distortion of essential health services in fragile and unprepared health systems. And health systems need to be prepared better for shocks. they need search capacity, they need other ways of working and doing for the health workers, support for health workers to be able to respond to shocks. We need information systems that are providing us the right data to make quick decisions on time. So, and most often, we also see that the most vulnerable people are actually affected by these interlinked shocks and stressors. They are already the ones that have the least access to services, and this is being made worse by polycrisis. So we need resilient health systems. We need health systems that are able to deliver quality and equitable health care for all. And this is something that we always need, also in calm times. So this is what we call everyday resilience. But then the second point, we need health systems that are able to remain core functions, essential functions in times of shocks. And they should have the capacity to absorb, adapt, and transform in changing environments. So the absorptive, adaptive, and transformative strategies of health systems, they are employed depending on the severity of the shock or the impact of the shock. So if the impact is relatively low, a health system can have an absorptive strategy as a strategy to react to that shock. But more often we need transformative strategies. Really a change in the way of working, a change in the structure of the health system to respond to a changing environment. So there is a lot of health systems resilience work going on within LSTM. And this is focusing on everyday resilience. So this is health system strengthening basically in calm times. And also on health systems resilience in the face of shocks and combined with stressors. And on this slide, we have presented some of the projects that are focused on health system strengthening and health systems resilience, but it's not exhaustive. There are many more. And many of these projects are led by the Department of International Public Health and some also by the Department of Clinical Sciences. But research led by other departments, by the other departments of LSTM, they also very much align with resilience needs. For example, research on long-acting injectable drugs, shorter treatment modalities, they are very helpful in times of shocks. Research on diagnostics and vaccines in the context of outbreaks are obviously very important when it comes to resilience. And then we have seen this morning the impact of climate change on vector control and what that means for vector control in the future. So it's important to connect these different researches that are all around resilience into one institute, the Institute for Resilient Health Systems at LSTM. And it's important to take the systems lens. The interventions that we are studying and that we are introducing, they might not be optimally implemented and reach their target populations if they are embedded in weak health systems that are not prepared for the upcoming shocks and stressors, and the current shocks and stressors, of course. So, we envision resilient health systems worldwide. That's quite a dream. And we would like to establish a network of researchers, health systems researchers that are working together with people from other disciplines and also multiple sectors, because we know that the health system is related to other systems, the economic system, environmental system. So we need multidisciplinary and transdisciplinary research, working with communities, practitioners, with policymakers to jointly see what type of resilience strategies can we come up with. And do they actually work, in which context, and particularly for whom? Because after all, we want to reduce avoidable and unfair differences in health worldwide. So this is what we have been doing so far, you can see the setup, like the core team that have been working in the past months on setting up the institute, which is going to be launched soon today. And we have been focusing quite a bit on East and Southern Africa, but we are envisioning that this Institute for Resilient Health Systems is going to have a phased approach towards regional hubs in also South Asia, Middle East and West Africa. And the coming months we will focus on setting up a scientific committee and an advisory committee, an external advisory committee that is going to bring this institute forward. So now I'm handing over to Jacinta, who is going to tell you a little bit about the 3 priority areas of the institute.
Thank you so much, Maurice, and thanks to everyone for joining us during this session. So I'm going to talk a little bit about the priority areas that we're beginning to think of in the Institute for Resilient Health System, hereby shortened to IRIS. And the first priority area that we're going to focus on is really advancing health system resilience research. And we're going to do this by building on what others are already doing in that area in terms of strengthening the work around health system resilience. So our conceptual starting points are informed by work that's been done by Blanchette, Top, and others. And our entry point in this area is to work across all levels of the health system. So from the community level, subnational, national, and international levels, we will work across all the 6 building blocks of the health system, but not just thinking about the health system only, but thinking a little bit more about its interdependence with other systems such as environmental and economic systems, so that we are able to generate knowledge that's a bit more diversified to help the health system have capacity to cope with uncertainties. So our first research focus area will be around the dimensions of resilience, and we will be doing exploratory research that looks at what capacities enable the health system to prepare, respond to shocks while maintaining everyday functioning. This exploratory research will then inform deeper explanatory research that will then start looking a little bit more into what strategies can be tapped on to build that resilience, but more importantly, whose decisions and interests are reflected in the strategies that are chosen to respond to the crisis that we face. The last bit of our resilience research focus is going to be on evaluating the outcome of those enacted strategies and thinking about health and health-related outcomes, but also really thinking about for whom those outcomes are intended. So again, back to really thinking about equity and who's represented in how we respond to crisis. One of the cross-cutting areas that we will be focusing on as we conduct this research is ensuring that we are conducting multisectoral and transdisciplinary research that is mainly driven by embedded forms of health systems research. We really want to take a very flexible approach to our research, trying to leverage on new methods that actually represent the local context in which we work, thinking about other new and innovative ways such as sleeper protocols that can be, again, tapped on very quickly in terms of crisis so that we don't delay the research that's needed at that time. We want to place high priority on rapid evidence synthesis so that we can help decision makers make decisions about what strategies to adopt in terms of crisis, but also continue strengthening a lot of our methodological strengths as LSTM in areas such as participatory action research. Our second priority area as an institute is to try and contribute to capacity strengthening. In this particular area, these are our early thoughts, and we are still discussing and talking with a lot of you through both internal and external consultations to see how we can strengthen this second priority area. In the first instance, we are really thinking about how we can strengthen research capacity, not just for individuals, but also for the institutions and the networks within which they are embedded. We're thinking about providing studentships to support research, but also policy translation that come from the research that these people do. We are also coming into this area by really starting off with institutions that have some form of structures and resources in place, being cognizant that institutions have got different strengths, but would like to start with those who have got some form of health system capacity or structures in place to ensure that we are embedding as much diverse, but also ensuring that we are capturing all the diverse country contexts within which health system resilience research can be done, with the view of generating evidence that is global and reflective of needs of entire populations. At the core of this capacity strengthening effort is creating a learning system so that there is knowledge exchange between the global South and North, but particularly between the South and South, ensuring there are forms of peer learning and open access to knowledge repositories that others can tap into who are interested in doing work around health system resilience, but also health system strengthening. Okay, I'm not sure what happened.
We're not having a third slide. Never mind about the third priority.
Well, as that comes up,
There we go. Magic fingers.
Thank you, John. Well, the last area is really around knowledge translation. And as IRIS, we want to create new knowledge, but also make sure that this knowledge gets into practice. So our interest here is not just to disseminate knowledge, but to make sure that we are also demonstrating the impact of the knowledge that we are producing as an institute. So we are thinking about changing knowledge and attitudes of people, making instrumental changes within the institutions and context within which we work. For example, making sure that government plans are reflective of what actions they are taking against risks, and also making sure that part of the work that we are doing gets into policy spaces and decisions. Most importantly, we want to make sure that the relationships that we build with the institutions and the individuals we do this research with are actually maintained and endured during our work, the entire phase of our work. We are thinking of different forms of effective knowledge translation strategies, and to do this, we really are focused on thinking about who, what, how, and types of knowledge that we want to disseminate, but also leveraging on already existing platforms that have got reach. We want to really think about that cycle so that as we generate knowledge and get into action, we are ensuring co-production with all our various stakeholders from the word go. So these really are the strategic areas that we've been working on as an institute for the last 5 months, and we are excited to share this early thinking with you as part of this session. But also please do come to our launch, which will happen, the clicker won't work, with my nice slide. Yeah. So please, welcome to our launch today at 6 p.m., where we hope to talk more about the work that we've been doing and also see how we might collaborate with each other going forward. Thanks.
Thank you so much, Jacinta and Marisa, for really explaining this frequently used term, resilience, which is really complex, and why health systems resilience is so critical, and outlining the IRIS focus priority areas. Here we are. This is the launch party at 6 p.m. tonight. So let's just have a few questions. We've got a couple of minutes. I'm going to go to the online for the any questions from online? No? Okay. So one person over here. Thank you.
Hello. Thank you. What are the plans for capacity building when the capacity to do an intervention is completely different from the capacity to evaluate a given intervention? All of my examples would be mosquitoes, but I just want to give it in a general sense.
Okay. Do you want to have a go? answering? Anybody?
I can give a specific one. So like micro-injecting or transgenic mosquitoes, right? Completely different skill set from evaluating the epidemiology and resistance management of that modification of a mosquito. So are there plans to do both the capacity to do an implementation and evaluate?
Yes, there are. Yeah.
Okay,
Because
cool.
we would like to do capacity building and strengthening for researchers, but also in terms of policy makers and practitioners to really see how they can enact the resilience strategies that they come up with. Yeah.
Good.
Thank you.
So we've got another couple here. And Dave and Fuad. And then we'll move on. Okay?
Thank you for the interesting talk. I'm Anna Tralfa from UK Health Security Agency. It's a really ambitious vision that you've got for health resilience worldwide, so congratulations on that ambition. I wonder, is it in IRIS's roadmap to take your experience and learning from those centres globally and actually conduct similar research here in Liverpool and the Northwest? Thanks.
Yes. Yeah.
Great.
We didn't stress that so much. But within the existing resilience work within LSTM, we already focused on Liverpool and beyond.
Yeah. Brill, thank you.
Thank you. So Dave and then Fuad. It's here. It's here. Thanks.
There used to be a fashion, even here in Liverpool, for something called health sector reform. In fact, I was the director of the health sector reform programme here. And there were two notable guys who used to work at Liverpool. One was David Nabarro, one was Andrew Cassells. And this largely concentrated on driving this model of public-private partnerships in various countries, and starting in the UK, using the UK evidence to extrapolate to Africa, Latin America, Southeast Asia. I wonder to what extent you would like to revisit some of that work, because I know WHO actually drove a lot of this stuff, because both of those guys got very high up in WHO and therefore have a lot of influence, I think. So I think you need to plug into that, because I think they could be a great use to you.
Yeah, thanks, Deb. I think that's a very useful suggestion. And I think even as we think about the different stakeholders and communities we are working with, we're also really thinking about not just the public health sector, but also the role of private and other sectors as well that interface with health. Thanks.
Okay. And just one final question for Fuad. And then
Thank you. So, although I work in Rebuild for Resilience and part of this new institute, but so the question is also to me, thinking about that. So one, 6 building blocks framework is a core in the process here. And my question is, does resilience of health system or resilience health system mean that we're talking about strengthening health system, the current health system, or we're open to completely or maybe partially change in the framework of health system that already has been shaped around the issue of, as you said, stable, settings, and we're facing now completely different worldwide. So to what extent you think that will affect that model, this framework, to a new, maybe, framework? Thank you.
Good question. This everyday resilience is very important, and that's the health system strengthening in calm times. But only that is not enough. We have seen that very strong health systems in the world actually did a bad job on responding to COVID-19, and maybe some of the weaker health systems did relatively better in their response. So there is more needed than just strong health systems. It is really this capacity to anticipate and to react to uncertainties. And indeed, like what you're saying, the 6 health systems building blocks are there, but more importantly, I think, to look at the software elements of the health system, so really the actors' interests, power, their underlying norms and values that are all playing a role in the relationships. And that's really what we need to look at, I think. Thank you.
Great. Now let's give them a round of applause and thank them very much for their presentations and questions. Okay. So next up, we have Dr. Chu Chu Tan, who is a research director at Burnett Institute in Myanmar, and Dr. Wessam Mansour, a researcher at LSTM. They're going to be talking about health systems in fragile and conflict-affected settings.
Good morning, everyone, and thank you for having us today. Today, and together with Dr. Chu Chu from the Myanmar team of Rebuild for Resilience, we will present health system responses in fragile and conflict-affected settings. But first, let me introduce you to the Rebuild for Resilience program. So, Rebuild for Resilience is a big research program that focuses on strengthening health system resilience in 4 fragile countries: Lebanon, Myanmar, Sierra Leone, and Nepal. Our aim is to address the unique challenges faced by health systems in fragile and conflict-affected settings. You may already have an idea about the challenges these settings present, but today we will delve into the real world to know more about what's actually happening on the ground and what it means by conducting research in this challenging environment. We will share 2 case studies. I will start with Lebanon, and then Chu Chu will show the case of Myanmar. To be honest, the situation in Lebanon is incredibly complex, shaped by a series of crises that began with the influx of Syrian refugees in 2011, reaching its peak in 2015. This crisis was exacerbated by the economic collapse in 2019, and then the COVID-19 and the Beirut explosion in 2020, and recently, of course, by the ongoing war. The layering of these crises has had a devastating impact on the Lebanon's health system, making it extremely difficult to provide access to quality health care for population. And these challenges have disproportionately affected vulnerable population, especially Syrian refugees. At the local level, where there is no well-established local health system, there are numerous organizations and local NGOs operate in isolation and often pursuing their own agendas. This has led to a duplication of health services, lack of coordination, particularly with the emergence of the parallel informal health sectors trying to address the needs of Syrian refugees. So these situations really highlights the lack of health governance and planning and leaving population needs unmet. In response to these challenges, we have used a participatory action research in Rebuild to support the establishment of the Municipal Health Committee in the municipality of Majd al-Anjar. A key feature of this committee is its inclusivity. It brings together all local health actors and key stakeholders, including the Lebanese host community and the Syrian and Palestinian refugees. And to ensure effective collaboration, we have an embedded researcher from the local community who facilitates the work, maintains continuous community engagement, and ensures that decisions are evidence-based. The overall aim of this Municipal Health Committee is to strengthen the local health governance and improve service delivery to better address the needs of vulnerable groups. What this Municipal Health Committee has done to date, they have successfully implemented several community-led health initiatives such as the health education program, including breastfeeding awareness campaign and school health program. There is also the control over supply of medication initiatives and redistribute these medications to people most in need. And there is also another initiative that lead to the establishment of a virtual blood bank. Last year, and since the start of the war in Gaza, the Municipal Health Committee worked to develop its emergency preparedness plan. And after the onset of the conflict in Lebanon, they started to activate this emergency plan to be able to accommodate the needs of the high number of influx internally displaced population from the south into the municipality. So they tried to address the growing needs of this new population in the municipality. In conclusion, the MHC, or the Municipal Health Committee in Majd al-Anjar, has empowered marginalized groups to participate in healthcare governance. This has helped to build the community trust and also to promote evidence-based practices. And the localized community-led governance structure can serve as a model to improve healthcare during the time of crisis. And this is what we are trying to replicate in Lebanon and beyond. Thank you. And now I'm handing over to Dr. Chuchu to take us through the case of Myanmar. Thank you.
Good morning, everyone. Now I will be taking you to a different health system, but I will be talking on more of a practical aspect of working in a fragile and conflict setting as a researcher. So when you look at Myanmar, it's a beautiful country in Southeast Asia, surrounded by the big giants, India and China. But many of you may know that when you think about Myanmar, you would first come in mind our eminent leader, the Nobel Peace Prize winner, Aung San Suu Kyi. During her times as a democratic nation, there was a big poly crisis, which you call it the Rohingya crisis that everyone knows, and of course the COVID pandemic. But the military coup of 2021 has changed all our lives. And looking at the map of Myanmar, you can see all red, meaning that conflict is everywhere, not only in the border areas, but in the whole country. So in these type of emergencies, these type of fragile and conflict settings, essential care that you talked about, like antimicrobial resistance, immunizations, malaria, all exceeds because emergency care is utmost important. When we say emergency care is not in a big hospital. You may see that it's in a little hut, it may be, with limited healthcare workers, minimal essential drugs, and health service that we can be providing. And really reaching to the most in needs. Because conflict is everywhere, compounded by the climate, reaching to the most in need is very difficult. On the right-hand side, under the umbrella is me going to a research site, which took me 4 hours walking to reach to where I wanted to be going, and it is not an easy road. So, in our country, as you all may have heard of the health worker crisis, which is the civil disobedient movement of health workers against the government. So when you become a CDM worker, the government really restricts you on with penalties, detainment, and it really restricts you on going out of the country and even working in the country, both in private sectors, because you will not be working in the public sector. But on the other hand, if you are left in the public sector for any reasons, there is only 1/3 of the health workers left in the public system, where over patients compounding stress and also social punishment because you are still working in the public sector. So being a health worker in a country like mine is like a salt between the beans. Health workers are essential, but stuck between politics and people. And another thing is, when you work in a country like Myanmar, we must understand the rules and regulations of the government. Many of the memorandum of understanding with many of the NGOs has not been re-established. And with the UN and other organizations really talking about not working with the government, meaning non-government engagement. But in reality, when you do want to work for the people inside the country, we do have to face difficulties. So we become hand in hand. UN, NGOs, CBOs work in hand, cohesively and collectively in a very informal manner. So if you really wanted to be working in a fragile and complex setting like mine, you must really understand the context in which your health facilities can be bombed anytime within yourself. And the community health system that is really working on ground with the local people are very much important in serving the local community. So you must understand the context. Another thing is the funding. As there is a global competition of funding, the funding towards these fragile and conflict settings are shrinking. However, conflict and fragility is everywhere. So if you really want to hear about the real evidence and the people's day-to-day life, the funders must understand and the flexibility that fundings need to be towards these fragile and conflict settings are important. Another thing is safety. When I talk about safety, the basic principle, ethical principles of anonymity, doing no harm, is very important, not only for research participants, because research is a sensitive issue in Myanmar. Even for publishing research outputs, like myself, my name is Dr. Juju Than, but you will see articles with Than K, meaning that anonymity of myself is also very important in these fragile and conflict settings. And many of the research that we are doing with the Rebuild for Resilience has put us into a new arena of how to work in fragile setting together with LSTM leadership. It's amazing, and I am very proud to be working with Rebuild for Resilience. But last but not the least, I would like to tell the global community as, without peace, I think the global health system cannot be achieved. Thank you.
Thank you so much for that really powerful and moving narrative of working in these particularly challenging settings. So I open the floor to questions. We've just got a minute or 2 minutes. Anything, Clara?
No, just to say, there was one question at the end of the last session from Caroline Bauer saying, how feasible are these strategies in conflict-stricken countries where the need is the greatest? Which I think Wessam and Choo have answered that already, so well done.
Okay, all right. Anything from inside here? Yes, please.
Hello, thank you so much for this interesting presentation. I have a question regarding the situation in Lebanon. And it's fantastic to see all this initiative and to engage the community and to strengthen the health system in Majd al-Anjar. And we have seen many initiatives in other cities across Lebanon. But for me, I believe that the main challenge is the sustainability of such kind of initiative. And how can we ensure that when the external support end up, when the funds end up, how can we ensure that the local community can continue to do to follow this initiative? And is it better to involve or to engage more the Ministry of Health? So she can supervise or make sure that when the external support end up, we should continue. And my second question, did you measure or have you measured the impact of this initiative so far to see, shall we next time do it the same way or engage more people, etc.? Thank you.
Thank you for your question. Actually, everything in the municipality of Majd al-Anjar and in the municipal health committee is led by the community. It's not us. We just facilitated the process and brought them all together, but they are doing all the work by themselves. So I think this is a promising step that they will be able to sustain the initiative and continue, because it's already there. The Municipal Health Committee is already there, led by the community, led by the people from the health committee in the municipality. Okay, we just organized the process and they are proceeding with it. So I think it will be sustainable, hopefully. Yeah. For the impact, yes, actually, we are going through an evaluation process from time to time, and we do reflective meetings to identify what we have learned and what have been done, how successful was it, what we need to change. So this is like an iterative process, and they are actually managing it and trying to update or change whatever needs to be changed. So I think that is kind of an end. Thank you.
Okay, thanks so much. I think we'll connect later, okay, for those other questions. So thank you very much, Chuchu and Wessam. Okay, so now for something a little bit different. We have a 10-minute film documenting a learning exchange between Kenya and Liverpool about community health systems and the health workforce. We'll show this film and then there will be time for a few questions afterwards. It's hot off the press, so you're the first ones to see it here. So let's see if we can get it to work. That's not good.
Big ideas right now can change the world. Yeah. Just this moment right now can make a difference. Yeah.
This program is called the Transforming the Community Health Workforce. It's an exchange program of mutual learning between Homa Bay County in Western Kenya and Liverpool.
Usually we talk about south-to-south learning, but in this case it's a learning exchange between the southern hemisphere and the northern hemisphere. So it's south to north and north to south, shared learning.
Can make a difference.
The idea behind this project is that Kenya and Homa Bay County are quite advanced in community health programming, while on the other side, Liverpool has elaborate primary care networks. So UK as a country has had primary care networks for a long time. So Kenya is currently trying to implement primary care networks, and Liverpool is currently trying to improve its community health program.
It's focused on the community health workforce, and we've paired up 6 individuals at those different levels. From Director of Public Health level to medical services, to youth advocates, to people working with vulnerable groups, to community health leads, to create change-maker pairs.
I'm very excited to be here. I want to learn more about community health implementation here in the UK.
I've been to England many times, but I've never been to Liverpool. I'm just beginning to wonder, why didn't I come to this beautiful city?
So for me in Liverpool is to see what are the convergence areas in the context of community health. What are the new things that are happening here that is not happening in Kenya, and what is there in Kenya that my counterpart please can actually learn and implement.
Basically my expectation for this week is that we'll be better off than we came, by exchanging what we know, what we have, our experiences, but more importantly, to know what is happening here, especially under the space of primary healthcare networks.
So when we're thinking about the structure of the NHS, what we have is the Department of Health and Social Care.
We started with an overview of the UK health system. We've done community visits, we've visited organisations, and we've also done health centre visits and the emergency room. The Lord Mayor hosted us in a civic reception. We actually then took them around the School of Tropical Medicine, exposed them to some of our research and academics. The snakebite tour was a great event. We held a mini symposium here with academics. People have done shadowing of their counterpart, spend the day with them, see what their day-to-day job is like.
Let us break boundaries and dare to be different. Oh, different. This is not a paper exercise. It is everything that we need right now.
The week has been good, a very busy week, a lot of learning. Learning from the culture, connecting with people. So it was a very good week and a busy one as well.
It was so boss. But what I've learned is how organized the workforce planning is. I was just telling Melissa, so her team is really a tight ship. So I just want to borrow those lessons and go back home and work my team into the tight ship that I have seen. We shake hands. Hello, how are you? Good. So please expect this.
There are a lot of areas where we converge in terms of ideas, in terms of practice, and also areas where we also need to, the UK needs to learn from Kenya also.
Yes, so we have the exchange. We'll be going to Kenya. I'm going, and I've just told Emily I want to go to the community. I want to see how those services are provided, but also see what the community is like, what are the needs, what is the uniqueness of them, and how the healthcare providers and community health promoters, how they tailor their work to make sure that they can deliver best quality care and best quality support to the communities.
Yeah, really excited. So we've been asking Lynette and Emily, me and Dagmar all week about different questions about Kenya and what to expect from Homa Bay, but everything they've told us sounds amazing, so we're just really excited to get over there and see how they work with their communities and what learning we can bring back home with us back to Liverpool.
What was happening this week is that we were having an exchange visit from a team from Liverpool City Council coming to visit Homa Bay County. So the program was structured around change maker pairs, and so for each visit there was time set aside for change maker pairs to shadow each other.
Most of all, I was very excited to come. We've been hearing about Kenya for maybe the last 12 months through the Liverpool School of Tropical Medicine and the projects that Kenya and Liverpool share.
Had the chance with the LVCT to go into settlements in Nairobi and see how the community engagement and community mobilisation and advocacy looks like on that level. And then obviously we've managed to come into Homa Bay.
I think hearing it and seeing it in real life is very, very different. So it's been really interesting today to attend with the healthcare facility and obviously to come and see the community health workers out in their communities.
And I also think the fact that we are using community feedback to inform how we offer services. I think that's a similarity, different context, but I think that's what we are all passing.
And if you look at the dream of the PCNs in Kenya is exactly what is happening in England. Every citizen should know, when I get sick, what is this primary network that I am in? Which is the next facility that I should go in or I should go to? How is the referral system, both upwards and backwards?
People here really support football.
watch Premier League and
Yeah,
support football.
I know that.
So the best practice, like in your facility, the way you've integrated sporting events into young people and also reaching to young people, that's also another thing that we can learn. So that we try to use sport as a tool to mobilize young people to affect services.
With us, we use sport and the arts and creativity. So we do a lot of creative activity with our young people. We've built a 3G football pitch. We're now building other facilities there. That is for young people and adults and everyone else, because we also see that as part of well-being.
You guys have a more engaged community outreach team, so I think there is a potential to learn how we could incorporate elements of that.
Yeah, I think it's very important to share ideas from the global south and the global north, and they just share these experiences and learn from each other.
Big ideas right now can change the world. Change the world,
I mean, this is just putting a toe in the water, really. It's the beginning of doing work this way, learning from the global south, having mutual exchange.
We are very happy to see that both teams learned something from each other. So, for example, the Kenya team were able to visualize and understand how primary care networks work. The Liverpool team were able to take away a lot about our community engagement, the real engaging the communities, the community health workers being empowered.
The shadowing is especially fantastic because the experience is very organic. We are not in a classroom set up. We're just out there doing our work and then getting to experience each other's work. It's just been amazing.
We already have intentions to hopefully meet again this year to work in collaboration about how we can embed some of this work into Liverpool's way of working. We've talked about other potential projects that we might be able to work on. And then there's the opportunity for us as individual and professionals to work together to share learning and growth along the way. And all of this has been made possible by this project.
Right now, right now, right now, right now, right now.
Oh, what a great film. Big ideas changing the world. And I think we should do that dance to warm ourselves up, actually. But anyway, I want to welcome Lillian and Miriam just to the stage and see if there are any very brief questions that we could ask them now. And anything that anyone wants to ask. Anything on the... No, nothing online? Nothing? Oh, you let off? Oh, no, hang on, Sally. Go ahead, Sally.
Really inspiring learning and partnership. So what lessons do you have for others wanting to have the same engagement and south-north, north-south learning?
I think keeping a focus helped us. We focused it on community. Homer Bay is one county. It has 2,975 community health workers. In Liverpool, we've got 11. And we have a very fragmented kind of system, and Homer Bay has this very structured system. So keeping it focused on one area there to start with. But it's lessons that there's other things, it could be a different area, but that was helpful, keeping it focused like that. And you probably saw from the film, for me as well, there was that actual relationship building and trust and time over 12 months, which started far, far before the actual visits, and then in between the visits, and then after the visits. So it's not just exchange visit per se, it's the programme of building the relationships. And it builds on a relationship between us for a very long time as well.
Yes, it was interesting, very nice. One of the key lessons we both learned is that first, most of you as researchers have seen many parts of the world. So you've seen poverty, you've seen rural and urban context. Not everybody has, so sometimes it can be a bit shocking for visitors who were very shocked at the extent of the suffering, but also appreciated how much that communities can do for themselves to uplift themselves, even with the minimal resources, as you keep building on that. So it was good to also see that lens, what communities are able to do, and on both sides, and how it was also surprising to the Kenyan team to see poverty in Liverpool. Yeah.
Okay, let's give them another round of applause. Thank you so much. Okay, so next up is Justin Pulford, who's the Deputy Head of the Centre for Capacity Research, and he's going to be talking about capacity research and health systems resilience. So over to you, Justin.
Thank you, Jo, and thank you everyone for attending. Excellent. So, the topic for my talk is capacity strengthening, resilient health systems, and equitable partnerships. So, 3 very big things, all in their own right, which I'm going to coherently bring together in 10 minutes. So, good luck to everybody, mostly myself. But I'm going to employ a few tricks to try and achieve this. So firstly, I'm going to narrow what I mean by health capacity strengthening to health research capacity strengthening. And to start with, I'm just going to draw a connection between health research capacity strengthening and resilient health systems. I'll start with this definition of what I mean by health research capacity strengthening. I won't read that out. I think you can all do that on the screens in front of you. But my main reason for putting it up is so that you know what I'm talking about, but also to make explicit that when we talk about health research capacity strengthening, we include sort of national health research systems. They're part of the focus of research capacity strengthening. So what is a health research system? Where might we find it? And what's its relationship to the health system? This diagram, I think, is very helpfully illustrates that. So a health research system is fundamentally a fundamental link, overlap between the health system and the broader research system. So parts of the health system are also parts of the health research system. Obviously, parts of the research system are also parts of the health research system, and it also has its own unique features as well. So there's clearly a system overlap and dependency. So if we're going to talk about resilient health systems, we also need to understand that strong national health research systems are also important. And I think this has been really clearly illustrated by COVID-19. So to prepare for and respond to shocks and stresses within a health system requires a robust, flexible and comprehensive health research capacity at the national level. So my graphic here is of the COVID-19 vaccine, which I think is a recent and really quite impressive example of national health research systems responding to a major health research or health crisis. So again, illustrating that system overlap and dependency. But when we think about COVID-19, although the development of the vaccine perhaps leads the highlight reels, health research capacity was also essential to all the sort of behavioural and policy interventions prior to the vaccine development, essential to the sort of achieving good rollout, coverage, uptake of the vaccine itself. And I think if we looked across LSTM at the time of COVID-19 in the UK, so many research teams mobilised in different ways. And many of them were not working on the vaccine at all, but other things equally important. So there's a clear overlap and dependency between health research capacity and resilient health systems. So what does a well-capacitated national health research system look like? Quite a tough question, and perhaps there's not a universally agreed answer to this, but one answer, which is promoted by the WHO, so let's go with that, is on the slide here. And it describes a national health research system as consisting of 4 key functions and 9 kind of components across those functions. So the functions are stewardship, financing, creating and sustaining resources, and producing and using research, which perhaps LSTM is most familiar with. I won't go through the components. You will have done that yourself. And I'll come back to this shortly. But that's what a strong national health research system should look like, perhaps. So the broad implications for capacity strengthening here are manyfold, really, but there are three I'm going to focus on. First is that if we want to strengthen national health research capacity, then it requires a systemic approach. If we disproportionately invest in any one of those functions or only some of those components, then we're not strengthening the system. We might, in fact, be constraining it or undermining it. A second key point is that a national health research system can be both a recipient and provider of capacity strengthening activities, and it's activities that foster the latter that are more likely to be sustainable. And perhaps just to illustrate a bit more what I mean by that, is if we look at the third function of a strong national health research system, creating and sustaining resources, that essentially speaks to a system having the capacity to strengthen itself, which is quite different to providing external support to build up a system. The third key implication is that no one capacity strengthening initiative will be sufficient on its own. We can't do sort of one thing that's going to strengthen a national research system. But if we work in isolation in our individual efforts and are not cognizant of previous sort of current and future capacity strengthening initiatives across that system, then that might be problematic. So, now, this is where I attempt to bring it all together. So going back to the title with a slight caveat of health research capacity strengthening, resilient health systems and equitable partnerships. And I think in modern parlance, this is where I'm attempting the weave, as it's come to be known. And there are seven key points here, which I've got on the screens in front of you all. So the first is that international research partnerships are a major vehicle for health research capacity strengthening. They're not the only vehicle, but they are a major platform for how LSTM, the UK, invests in research capacity strengthening elsewhere. Most of those partnerships have a particular sort of scientific focus, and in most cases the scientific focus is not health system strengthening. However, irrespective of the scientific focus, because of that overlap between resilient health systems and strong national health research systems, international research partnerships of any variety have the potential to contribute towards stronger, more resilient health systems. But realising that potential requires the partnership to be cognizant of the health research capacity strengthening sort of practice implications previously described. So we know international research partnerships often have a research capacity strengthening objective. In some cases, it's the primary objective for being. More commonly, it's a secondary objective. So there's a scientific objective, but also importance to demonstrate that research capacity has been strengthened as a result. In terms of designing those programs, thinking about those key priorities of are our approaches strengthening the system or contributing to system strengthening, or are we disproportionately investing in one part of it? Is what we are doing sustainable? Are we helping the system to strengthen itself, or are we just adding a sort of an external thing that's time limited? And is what we're doing complementary to other capacity strengthening activities, or are we just repeating the sort of same thing that everyone else has kind of done or doing anyway? If we start to think about those three things, and this is where it gets a bit tricky, practicing health research capacity strengthening in that way may sometimes compromise the immediate needs of the partnership. So what you need for your research partnership to be successful, and the capacity strengthening aims to ensure those things are successful, might not necessarily support system strengthening in itself. So there might be a need to compromise. So to illustrate that, if we consistently work with the strongest partners in the countries we partner with, then are we really supporting capacity strengthening across the system in that context, if we always favour the strongest? If we create parallel structures to avoid or circumvent complexities in those environments? Are we strengthening the system, or are we continuing to undermine or constrain it? But in making those choices, we may then be making it harder to achieve our project or partnership objectives. So some compromise is needed. The key point here being, if we consistently prioritise our project objectives over maybe the harder, systemic, sort of sustainable, complementary capacity strengthening objectives, then I ask the question and complete the weave, is that actually equitable partnership? Within a global health context where health systems resilience is essential to sustain population health and development impact. So I end with a question, and I end on time. Thank you all for listening.
Hey, well done, Justin. And thanks so much for doing that tricky weave. I've got time for just one very, very quick question. Very quick question. Nothing go? Yes, make it very quick.
Thank you, Justin. I was just going to ask about compromise. You've spoken about compromise and research capacity strengthening. So how do you strengthen capacity while not compromising the quality of the research? Thank you.
Okay. Quick question, really difficult answer. I guess the point is to consider the compromises, to not always take the easy option. Obviously, depending on funds and time, you might have more leeway to take the harder option. It might not be possible, but if it's never considered, then it will never happen. And on our desk out the front are some good practice and research capacity strengthening user guides, which will give some useful tips for how you might do that.
Great. Well done, Justin. Thank you very much. And a great plug for your stall, for your stand there. Okay, so finally, we've got our keynote speaker today is Dr. Sushil Baral. Now, Sushil started his work as a community health worker in a remote mountain in Nepal. He's since then has developed into a public health researcher with more than 30 years' experience in health.